I would like to congratulate the organizers of the Asia-Oceania Society of Physical and Rehabilitation Medicine for organizing this webinar. And in particular, I would like to thank Dr. Ray Matias for inviting me to talk in this very prestigious forum. And I would like to greet each one, good evening, good morning, and good afternoon, wherever you are in this part of the world. Now, the topic that I would like to share with you this afternoon, this morning, or this evening is on the interventional ultrasound for the wrist and hand. This is a very challenging area to do interventional ultrasound because of its size and also because of the intricacies of the structures that we are trying to approach. And so I would like to encourage everyone that as we go ahead with this talk, that you go and review so that you will be able to understand better what these procedures can help you in your practice wherever you are in this part of Asia and in the world. So I would like to begin my talk by sharing with you a Bible text which is found in Isaiah 40, 30 and 31. It says, "Even the youth shall faint and be weary, and the young men shall utterly fall, but they that wait upon the Lord shall renew their strength. They shall mount up with wings as eagles. They shall run and not be weary, and they shall walk and not faint." This is one of my favorite Bible texts because as physicians, we do not know everything. And so we rely on the higher power above us, and that is God, who can guide us what is best for our patients and can help us do the things that is very difficult for us to solve in our own way. So I would like to share with you this outline of our presentation today. And every subject that I would like to discuss will always begin with an anatomy of that specific area. And then I would also introduce the clinical approaches to the wrist and the hand. And of course, correlation of these symptoms with what we see in the ultrasound findings. And lastly, what interventional approaches is appropriate for that particular area in the wrist and hand. So what are the indications for doing ultrasound-guided wrist and hand injections? Now, there are two parts here. We have the diagnostics, and of course, the other one is therapeutic. In the diagnostic, what we would like to find out is to know what exactly is causing the problem when we try to inject a patient. And so we already have a basis for doing that procedure. And sometimes for most of us who are doing ultrasound, we have seen in the ultrasound a certain abnormality, and we would like to find out what exactly is the extent and the diagnosis of that problem. And so it is very important to always begin with the diagnosis. So here, you would like to aspirate the fluid. And so it usually appears as a black or anechoic image in the ultrasound. And so it could be found either in the joint or in the tendons. And of course, we can also use this to get tissue in the case of a biopsy of a synovium, or if there is a mass or a cyst in those areas, then you'll be able to find out exactly what the characteristics of that cyst is. So those are the things that we would like to find out diagnostically. Now, therapeutically, after we have probably discovered the nature of the aspirate, then we would like to remove it. And of course, it could be in the form of course, this is the hand. It could be a ganglion cyst, or it could be a fusion, or it could be an infectious disease. And then, of course, the last one would be, what type of solutions do we need to do to inject? Now, most of practitioners would usually inject steroids. But for some who have learned regenerative injection therapy, you would like to either use PRP or cytokines or bone marrow or probably fat, micronized fat. So depending on what kind of regenerative solutions will we use, then we can choose it depending on the findings that we see. Then of course, for those with pain, we can use dextrose 5% water, which is what they call the neural prolotherapy, which is very effective for superficial nerve pain. And of course, for those that doesn't respond with dextrose 5% water, then we can use the more advanced technique solution, which by the use of alpha-2 macroglobulin or A2M, which is actually intended for inflammatory process and of course for nerve injuries. So what are the points to consider? Now, first of all, we would like to choose which probe are we going to use. And usually we would like to use the higher megahertz, at least 10. The higher is better, of course, so that we can see the more superficial area that we would like to visualize when we do the procedures. But of course, we should not forget that in the background, of course, we should have already taken the clinical history, which is very important. We cannot just proceed with injection without the benefit of knowing what exactly is the cause of the disease. So clinical history is very important. Now, for those of you who are doing ultrasound, ergonomics is as important as the injection itself. If you have a very poor ergonomics, then it might be very difficult for you to inject and reach the target. So the line of sight should be the same. So let's say, for example, you have the patient in front of you, then the needle right where the probe is, and then of course the ultrasound image is right in front of you as well. So you are looking at the same line of sight. And of course, when you do that, you can be sure that you reach your target quite easily and adequately. Then of course, identifying your dominant eye is very important. Which eye is dominant for you? Is it the right or the left? And one technique of identifying that is just to use to look at this hole in your finger and then look at the hole very carefully. And when you close one eye and it's still on that hole, then that is your dominant eye. But if you close one eye and then you don't see it, then that is in order to see the target when you inject. And then of course, consent procedure is important. You ask the patient to sign a consent and that he understands exactly what you're supposed to do, what you're about to do to him, so he understands that. And so he needs to sign that. And of course, aseptic technique is very important. You clean it with whatever, betadine, or you can use a combination of alcohol and chlorhexidine, or there are other aseptic solutions that you can use. So those are very important. Then since the fingers are usually irregular, even in spite of the fact that you use a gel, sometimes you won't be able to see the entire structures. So you develop what we call the gel standoff. You put a lot of gel on the probe in order to see through the gel the structures that you would like to see. And so you see a beautiful image of what you would like to target between the wrist and the hand and of course the probe. Then of course, very important as well is avoid injecting air, because the moment there is an air in the solution that you're injecting, it usually will interfere with the image. So the moment you inject air, it will appear in the area as a white portion, and then sometimes it will interfere with your mobility, and that your injection will also affect the areas, and you don't see the image that you're trying to see. Then of course, approaches, is it in plane or out of plane? So we'll try to teach you later on how to really do it. And then needle gauge, at least 22 gauge is very important, and at least 1.5 to about 2 inch in terms of length. Or you can use a spinal needle if you want more leverage when you try to inject the area. And of course, the choice of therapeutic solutions, as we have already mentioned earlier. So here, this is a case of a 37-year-old female who complained of locking of the middle finger for 6 months. So the patient comes to you and the patient says, "Doctor, I have some problems on my finger And every time I close my finger, I can hardly extend it again. So what could be the problem? So you do an ultrasound, and when you do an ultrasound, this is what you see. So there is this flexor tendons right here. And then, of course, this is the flexor side of the palm of the hand and the finger. And then you know that in each area, there are different pulley system that is in the finger. So you identify that there is thickening of the pulley here. And in particular, this is the A1 pulley at the level of the metacarpophalangeal joint. And so you see, okay, there's thickening here, and probably this is the one that's causing the locking when you actually bend and then extend the fingers. And then, of course, you check it by doing a short axis view, and you also see an anechoic area here. And then, of course, there's a slight thickening on this spot right here. So you're sure that you're dealing with a condition which is commonly called the trigger finger. Okay, so when we go to the anatomy, look at this. So we have different pulley systems. So it's named depending on the area. So we have A1, we have A2, we have A3. And you will notice that the A, let's say the A1, A3, A5, these are all odd numbers. They correspond to this respective joints. So let's say, for example, the A1 here, which is the very most common affected area. This is at the level of the MCP of the metacarpophalangeal joint. The A3 corresponds to the PIP or the proximal interphalangeal joint. And then, of course, the A5 at the DIP or distal interphalangeal joint. And you also notice that there are even numbers, A2, for instance. This is in between your A1 and your A3, okay? So it wraps around this area here to stabilize the movement of the two flexor tendons, namely your flexor digitorum profundus and your superficialis. Then you will notice that there is also a cross-like pulley here, which is named as C1, C2, or C3. Now, the reason why it's called C is because it is crossing against it, or it's called cruciate. So they interlaced on each other and forming an intersection in that area. So that is where that's how it's being named on those specific areas that's being affected. So the most common one is A1 or the MCP, at the level of the MCP. So this is usually the most common affected pulley system in our body. So whenever patient comes to you, you will always point to the middle finger here and then at the level of the MCP. And so you can be sure that you're dealing with an A1 pulley that is thickened. So usually the A1 pulley, as mentioned earlier, arises from the volar plate. So the volar plate is right below, which is right here at this area. And then it's about 5 millimeter proximal to the joint and extends to the base of the proximal phalanx with an average length about 1 centimeter. So it's very short. And then the proximal edge lies approximately 2 centimeters from the proximal finger crease. So if you look at the finger crease here, it's about 2 centimeters below, okay, so or proximally. So it's not really where the crease is located. So if you look at the finger crease, you have to move it a little downwards to be able to see the lines and then identify where exactly the E1 pulley's location is. And then, of course, the distal edge of the pulley lies approximately 1 centimeter from the finger crease. So it's almost like that. And then, of course, as we mentioned earlier, if this is your pulley system, then there are two tendons that lies underneath that. We have the flexor digitorum superficialis and flexor digitorum profundus right here. So those are the tendons that is being stabilized by this pulley system. So most of the time, it's A1 pulley that is affected, and it could be associated with diseases like diabetes mellitus, RA, and gout. So try to check that if that is also present, that could aggravate the symptoms of all of these problems. Or it could cause big trauma, or sometimes there are really no established causes. So as we mentioned earlier, it can only be visualized by high frequency ultrasound. So if you're using an entry-level ultrasound, you might not be able to see it. So it's better for you to use a better kind of ultrasound to be able to visualize it. And of course, it will show us a hypoechoic layer right here. And then it's thin, and it's located volar to the flexor tendons and just proximal to the MCP joint. So the findings that you can see actually could be an enlarged tendons. So in this case, if you look at the size of the tendons, they look similar. So there's really no enlargement, no swelling found here. Or it could be a tenosynovitis. Fluid really is found at the sheath of these tendons. Okay, they have a common sheath, so there could be some fluid here. In that case, that's the one that's causing it. It could be a thickened volar plate, or the volar plate here is thickened. Okay, right here. So sometimes you can feel that it's like a nodule. It's very obvious. Or it could just be a thickened A1 pulley. So in this case, it's a thickened A1 pulley here. So you can do a dynamic imaging. Sometimes it's very hard, because if you do a dynamic imaging of the fingers, you can also not be able to see it, because as the fingers move, it's painful for the patient. And then sometimes the locking mechanism is obstructed by the position of the fingers in relation to the probe. So it can kind of push the probe somewhere, and then you might not see it. But at least when you try to palpate it, and then when you try to move it, and you can see some nodules over the spot on the palm side of the finger, then you can just put the probe there and see the level of the MCP, if there's any thickening or any abnormality at the A1 pulley here, something like this. Okay. So this one is a video that will show an ultrasound-guided release of the A1 pulley. So try to watch this. So you can see the needle. That's the needle tip. It's the bevel is facing upwards, and then I am trying to approach here the A1 pulley. Can you see it? So the A1 pulley is right here. The needle moves all the way to the A1 pulley, trying to release this area, and then trying to decompress the area which is really causing the stenosing of or narrowing of this area of the tendons. So what solution? Well, it depends upon you. Sometimes you use steroids. In this case, I'm using a PRP. So I find that the effectivity is much better. Results are much better than just plain steroids. So case number 2. This is a 25-year-old male sustaining a fracture of the distal ulnar bone during a basketball game. So this is an interesting case. This is a basketball player, and he was complaining actually of pain right at the triangular fibrocartilage area at the ulnar side of the wrist, and I thought it was a defect at the triangular fibrocartilage. So as I look at it, this is what I saw. There's a distal fracture of the ulnar bone here. Okay, so it's possible that the triangular fibrocartilage is also affected, but the ultrasound is not a specific modality for diagnosing a triangular fibrocartilage defect. But as you can see, there's a tendon right above it, which is your extensor carpi ulnaris, and you can see some inflammatory process going on right here. So it could be a combination of a fracture with tendon problems at the same time. So I tried to look at the area at the TFC, and so this is your triquetrum, this is your ulna, and then you can see the triangular fibrocartilage right here. This is your extensor carpi ulnaris over here. And of course, if you try to look at the area actually, so this is almost the same. This is the ulna, this is the triquetrum, and then these are the structures, the different structures with the meniscus and triangular fibrocartilage of the TFC. So same holds true in this diagram here. So this is, I would say, a combination of a triangular fibrocartilage and of course a fracture at the same time of the distal ulnar bone. So same here. So what I did was to do a regenerative injection right here at the fracture site and see what happens. The reason for this procedure is that the patient doesn't like to do surgery. So he actually requested me, "Doc, can you just inject that area with PRP and let's see what happens." So that's exactly what I did. So I'm injecting right at the area of fracture, as you can see that. So this is the area of fracture. The needle goes all the way to that spot. So as you can see, it's very interesting how these procedures can be done in the office and how easily you can do it for as long as you have actually get used to the procedure itself, and you can do it right on the patient. And so 4 weeks post-treatment, this is the appearance. So there is some degree of alignment of this fracture. In fact, this one shows a better callus formation here in this area. And of course, there's still inflammatory processes ongoing at the extensor carpi ulnaris tendon. So patient was a little bit happy that the pain is not totally removed, but there is still pain, but at least it has decreased from the previous one. I just advise him to use a brace and just not to displace the area that was treated. Okay, so the next one is case number 3. This is a 50-year-old female complaining of numbness in the palm of her hands for 2 years duration. And so as you can see, this is a very common problems among females. Numbness in the palm of her hands for 2 years. Patient can still hold objects, and but I was looking at the grip. The grip is a little bit less on the right area, which is affected, and the left is much better. So I did an ultrasound scanning, and this is what I saw. So the median nerve has a cross-sectional area about 0.18. So this is a little bit swollen. The normal is at least 0.10. Okay, so this is an abnormality. And then if you see the median nerve in long axis, there is some kind of a notching over here. Okay, as you can see, this is similar in size, but as you move here, there's a subtle narrowing on this area. Okay, so this is where the narrowing happens, and this is where impingement happens in the median nerve on the right wrist. So what do we see? So here, what I'm just showing is the reference point by which we usually scan. So it's between the scaphoid and of course the pisiform. That's where you scan your median nerve. And this is a cadaveric findings of what you see between that carpal tunnel area. So let's see what we can view here in terms of the median nerve. So as you can see, the median nerve digs down into the flexor tendons right here from proximal to distal. And I was trying to look at other structures that might cause compression in this area, especially the presence of ganglion cysts, which could be missed if you have a very high magnification of that area. So it doesn't seem to have any problem. So this is at the level of the pronator quadratus. As you can see, this is the muscle of the pronator quadratus, and this is the median nerve right here. So there seems to be no other lesions that you can find in that area. So the carpal tunnel syndrome, okay, criteria for diagnosing is that the normal is about less than 8 millimeters squared. And then it's at the level of the pisiform and the navicular or scaphoid. And then of course, if you have more than 12 millimeters squared, it's already considered abnormal. And sometimes if you have between 8 to 12, it could be, you just play around whether it's still, some patient may not really show any symptoms, but it's swollen. So there could be findings like that. So the abnormal nerve may become enlarged. That could be due to the inflammation, fibrosis, edema, and demyelination. So these are contributory to the pathology of carpal tunnel syndrome. And then, of course, you also measure for the cross-sectional area, as we have mentioned, take out of the perimeter, the aspect ratio and strain. If you have a special type of ultrasound where you can actually measure the strain when you do elastography, that's very important because those are included in the parameters to evaluate carpal tunnel syndrome. And then, of course, if you don't do ultrasound, you can do nerve conduction study, and then you also evaluate the degree of abnormality. Or you can do measure it by means of tracing method. Rather than the ellipse, you can trace the entire nerve and see if there is any problem in that nerve area. So where do you scan? So you scan it first at the proximal part of the carpal tunnel. This is your flexor retinaculum here. So as you can see, this is the median nerve, this is the flexor tendons, and then you do that until you exit from the level of the hamate, okay? So, and the triquetrum right here. So you can see the flexor retinaculum moving this way. And then of course, this is the extent of your scan. So you can actually start from the level of the pronator quadratus and then go all the way to the distal part of the carpal bones, okay? At the level of the hamate, okay? So this is how you measure the cross-sectional area. So you go into the inner border of the echogenic epineurium, okay? So this is the area that you need to measure. Don't measure it outside this echogenic area because that's already your outer epineurium. So you go into the inner portion of the epineurium to measure your nerve when you do a cross-sectional area measurement. Of course, the reliability is high at the carpal tunnel. And of course, carpal tunnel at proximal carpal row is wider than the distal row. And then of course, the swelling of the median nerve and flattening of the median carpal tunnel should also be evaluated. Or if you are doing it at the level of the pronator quadratus, difference of 2 millimeters squared from the pronator quadratus level and at the carpal tunnel indicates also carpal tunnel disease, in spite of the fact that the measurement may be within the normal range of the cross-sectional area. So the sensitivity of this test is 99%, specificity is 100%. Okay, so here I did two approaches. I did the in-plane long axis view approach. And so let's see what happened here. So we're trying to hydrodissect the nerve and then approaching from the distal to the more proximal. And so you can see how the nerve is hydrodissected from this area, okay? And then, of course, you open it up. So some people prefer this technique, although I don't usually do it normally, but in this case, just for illustration, I did one patient for this purpose, just to see how hydrodissection of the peripheral nerve could take place. And then, of course, I'm just using here 5% dextrose. Or you can also do a short axis view in plane approach. So this is a cross-sectional area of the nerves. As you can see, the median nerve is hydrodissected initially on top, and then I move to the lower portion. Okay, and then you can see how it's being hydrodissected below. And so you can see the entire nerve being hydrodissected. So what is the difference? So the difference is that, as you can see in this approach, the approach is trying to clear the nerve both from the structures above and the structures below. So I prefer this technique. I think everybody prefers this technique over the long axis view. So this one will specifically target the area of swelling, and that you can do hydrodissection above and also below. Now, other things that you can find in a carpal tunnel syndrome is to do some measurements of the bowing. So you can measure the bowing from trapezium and hamate to your scaphoid, and if it is more than 4 millimeters, that is already an abnormality. So the flattening ratio is also more than 3 to 4 in distal carpal tunnel, which is also very controversial. We don't usually do that. Okay, and then of course, other findings could be just the loss of fascicular echotexture. The fascicles could not be visualized, although the size is the same or normal, but the fascicles tends to be more diffuse and they sort of join together. And then of course, there's also median nerve notching on the long axis. Okay, something like this. There's a notching right here. So this is swollen on this area and this is narrowing on this part. Or it could be a hyperechoic thinner muscles findings from fatty atrophy. So sometimes for chronic patients, let's say you can do an ultrasound of the thinner muscles just to check whether there are already fatty infiltration that give rise to it being hyperechoic, and that is an indication of a chronic impingement of the median nerve. Okay, now I mentioned this because this is one structural area that you might hit when you do the long axis in plane approach, inferior to superior. Remember the one that goes like this, okay? Not the one that goes this way. So if you actually go a little more to the radial side, you might hit this nerve, because this is what we call the thenar motor branch. This is the recurrent motor branch of the median nerve. This is $1 million nerve, because the moment you hit this nerve, it could right away affect paralysis of your thenar muscles. So be careful that you know exactly where you're injecting, because you might actually hit this nerve. So it arises from the median nerve, distal to the flexor retinaculum. It winds around the distal border of the retinaculum to reach the thenar muscles. So what are the muscles being innervated? The head of the flexor plexus brevis, apollinis pollicis, and occasionally the flexor first dorsal interossi. Now let's see how to locate that. So this is your median nerve. This is your flexor retinaculum right here. And so there's a break here when the median nerve goes out, and this is your thenar muscles. So when that breaks, you can see that break in the thenar muscles, then that's exactly the area where the recurrent motor branch exits from the median nerve. So let's see here. Okay, so take a look at this median nerve right here. See that? So I was scanning from above, below, and then I reached a point where you see the, okay, that's the flexor retinaculum, and then look at the break here. There's a break here, right? Okay, that's a break. That break is where the exit of the thenar motor branch is happening. Okay, and then I go up right back again. Now, if you haven't seen that quite well, let me just repeat that again. So that is your median nerve right here. So this is your flexor retinaculum, as you can see. Then I scan distally, and then look at the median nerve here, and then that's the flexor retinaculum. And then of course you see the break here. There's a break here. That break here is where the motor branch exits right here. Okay, so this is where the median nerve thenar motor branch exits like this. And as you can see, it resembles some kind of a swan neck. The swan neck. Okay, and that is how you can see that structure, and that is how you can avoid hitting that area if you're approaching from inferior to superior in a long axis in plane approach. Okay, what are the pearls in carpal tunnel scanning? Of course, you have to characterize between a tendon and a nerve. What's the difference? Well, if the probe is perpendicular, you can see the tendon to be hyperechoic. If it is not 90-degree perpendicular, then you see it to be hypoechoic to anechoic. The nerve doesn't change much. It's always hypo to anechoic. When measuring the median nerve, get the measurement of the inner border of the echogenic epineurium. You know that already. And then, of course, common areas for measurement is level of pronator quadratus, left to right comparison of the right and left hand, and identification of the areas of greatest swelling. Then, as I mentioned earlier, avoid too much magnification of the median nerve to avoid seeing a lesion under the carpal tunnel. So I would like you to remember that. So if you magnify too much, you might miss that area below, which you might have a ganglion cyst. And then, of course, in doing a long axis view in plane under dissection, avoid hitting the thenar motor branch. So you have to be careful, because it's $1 million nerve. How about if you do release? Okay, so some patients would do a surgical release of the flexor retinaculum. So is that good or bad? Well, it depends. There are indications for surgery, and there are also indications where you can just do conservative treatments. So again, there are ways to to measure it, but the most suitable parameter for assessing clinical recovery and early post-op is median nerve strain. So this is one a feature of ultrasound, and that is elastography, which you can use. And not ultrasound have this. So in my case, I'm using S8. So I have this one, so I can check the strain of the nerve because that measures the stiffness of the median nerve, if there's an edema or if there's a pseudoneuroma. If fibrosis is present in the nerve trap, for example, there's a decrease in size, and regaining elasticity may not be possible in such a short time. Thus, the decrease of the median nerve area is likely reflective of the reduction of intraneural edema after release. So an increase of strain was more consistent than the decrease of the area. So look for the strain first, because the strain will give you the recovery of the nerve post-operatively. And then, of course, this is an example of carpal tunnel syndrome status post-release. So what do you need to see? The flexure reticulum should appear interrupted. So if you look at this is the flexure reticulum here, and it's not interrupted. So it was post-release, but it's not totally cut off. So this is a failed release, okay? Then, of course, minimal hypoechoic scarring along the nerve can be normal. So, but this one is a hypertrophic scar. So this is not good. So there is a degree of, the sensation of numbness and pain will still be there. And then, of course, volar displacement of median nerve and potentially flexor tendons. Or it could be the presence of persistent nerve enlargement and visualization of flexor reticulum and recurrent carpal tunnel syndrome. So if the nerve size remains unchanged, then the release is not successful. And then, of course, you can see still the flexor retinaculum, just like this, it's not also successful. So it's a failed release. And then, of course, other things I mentioned already, the nerve elasticity, which can be measured by elastography, should always be done. So if you have elastography features and somebody referred to you a carpal tunnel status post-release and you would like to see the status, then this is the thing that you need to do. And then, of course, there are other things that you can see, like tenosynovitis, lipoma, in this case, mass, ganglion cyst, aberrant muscle bellies, most cases idiopathic. So there are other things that could cause carpal tunnel syndrome. So you have to look at that. And of course, you might want to see if there are two median nerves, a bifid nerve that could be present, or the persistent median artery. Okay, now here, I'm just showing you that why is it that there is still pain and weakness status post-release? Now, the reason for the pain could be this. I'm not saying this is the reason, but I'm saying this could be the reason. So there is a branch of the nerve that comes from the median nerve before it enters into the carpal tunnel. And this is what you call the palmar cutaneous branch. And this actually innervates this particular area in the palm of the hand. Now, what is the implication? If the surgeon is not aware of this structure and he does a release here, which is in this area here, look at this drawing, there is a release. This is exactly where that is. If you put the release here, you might actually injure this nerve and injure the palmar cutaneous branch, which is sensory in nature. And you can have persistent pain on that area because you actually severed that nerve here, which is actually branching out from the median nerve before it it enters into your carpal tunnel. What about the weakness? The weakness, as I mentioned earlier, because of the injury of the thenar motor branch right here. So again, be careful that you don't hit this and you're actually able to identify that structure. Case number 4. This is a 31-year-old pregnant patient complaining of pain over the radial side of the wrist in her 7th month of pregnancy. So we expect this to be present among pregnant women, especially as they reach the 3rd trimester. And that is because of the expansion of ligaments and loosening of the tendons, okay? So in this case, I did an ultrasound, and this is what I saw. So there is an inflammation happening around the first dorsal compartment of the wrist. which affects the abductor pollicis longus and extensor pollicis brevis. So look at this inflammation, like the power Doppler. This is exactly what I see. And then I did a long axis view, and this is also what I see. There's some kind of a tenosynovitis in this area. There's fluid here, and it's swelling is what's causing the pain. In the patient, I did a Finkelstein test, and then it's painful over here. So that actually indicates a diagnosis of the Quervain's disease. But of course, you can have other things there, like Wartenberg syndrome, wherein the nerve, the radial nerve sensory branch is right on top, could be also affected. Okay, so look at this extensor compartment. So we have actually 6. And so I just connect all these structures here, if you notice. So this is the first dorsal compartment. You will notice that I always starts with longus, longus, brevis, longus, brevis, longus. Notice that? So abductor pollicis longus, extensor pollicis brevis for compartment number 1, extensor carpal longus, extensor carpal brevis for compartment 2, extensor pollicis longus and extensor digitorum communis for 3 and 4, and of course so on and so forth. Now the point here is that I'm using Lister's tubercle as the reference, and by using this Lister's tubercle, I would be able to see that this is in between your compartment 3 and 2, and so I just move on the radial side and see the compartment 1 which is affected in this case, which is abductor pollicis longus and extensor pollicis brevis. So the Quervain's tenosynovitis is relatively common among pregnant women. Located at the first dorsal compartment. This is the most common tendinitis of the wrist. There is thickening of the first compartment tendons. So as you can see, there could be thickening on that area. Retinacular abnormalities are seen better in transverse view. And common findings include, we saw this anechoic fluid surrounding the tendon thickening, and intrasubstance tear sometimes. But in this case, we would have a tear. So there's no tear here. So this is another image that you can see with the Quervain's tenosynovitis. And of course, I did some intervention procedures here, and then I approached it from the dorsal to the palmar side. Some doctors would approach it from the palmar to the dorsal. I just would like to avoid hitting some structures like the artery there. That's why I prefer to use this approach. Okay, so I'm trying to inject right at the sheath of the first dorsal compartment, and I just use a combination of lidocaine and 5% dextrose. And after about 2 hours, the patient says there's no more pain. Okay, so I did not use steroids. I just use a combination, as I said, of 1% lidocaine and 5% dextrose. Okay, so case number 5, and I think this is the last one. This is a 49-year-old female complaining of numbness of the ulnar side of the finger for 2 years due to iatrogenic trauma. She recalled being injected somewhere and inadvertently hitting the ulnar nerve. And then, of course, there's already atrophy of the hypothenar muscles. So as you can see, I did an ultrasound of this Goyon's canal right here. This is an ulnar artery. This is an ulnar nerve. This is your pisiform. Okay. So if you can see, the fascicles are big. No, normally it should be smaller, but these are big ulnar nerve. Okay, so anatomically, this is what you see. So the ulnar nerve, it basically innervates most of the hypothenar muscles, or all the hypothenar muscles and some of the thenar muscles. So it goes all the way like this. So as you can see, this is how the ulnar nerve really innervates the palm of the hand. So it innervates the 5th and 1/2 of the 4th, and some muscles are also innervated right here by different branches of the ulnar nerve. So there's a lot of other branches. So these are what we call the deep motor branch of the ulnar nerve, innervating the first dorsal interossa and the adductor pollicis motor branch. Okay, so that's how the ulnar nerve is distributed. Now, taking a closer look, you will notice that as you go distal to the pisiform, you can see that there is a muscle there that pops out. This is your flexor digiti minimi. Now, this is a very important muscle. Why? Because the flexor digiti minimi will differentiate between the motor branch and the sensory branch of the ulnar nerve because it is right in between. So as you can see here, this is your superficial branch of the ulnar nerve. This is the deep branch of the ulnar nerve. So the deep branch is motor, the superficial branch is sensory. And right in between is the flexor digiti minimi. Okay, and then this is another view of the deep branch of the ulnar nerve. Okay, as you can see, it runs along different muscle layers. Okay, and then it goes all the way to the opposite side. So that is how the deep branch of the ulnar nerve innervates those muscles. And surprisingly, there is a motor branch of the superficial branch. We were saying the superficial branch is pure sensory, right? And the motor branch is pure motor. But in this case, the superficial branch has a small motor branch. And this small motor branch of the superficial ulnar nerve innervates your palmaris brevis muscle. So this is the muscle that contracts when you actually separate the fourth and the fifth finger like this. And this muscle is the one that activates. This is the palmaris brevis. So as you can see, the nerve is right below and the artery is right below as well. So it's all right below this muscle here. So the muscle here is shaped like this. There's a slope. Okay, this is another view and a contracted muscle. You can still see the nerve and the artery here. Okay, so just for you to understand that there is a motor branch of the superficial ulnar nerve, which is the distal branch of the ulnar nerve after entering the Guyon's canal. So significance, it's what we call the Guyon canal type 2 syndrome. Okay, that's the deep branch because the other branch, type 1, includes both the sensory and the motor. And this is seen among bikers, jackhammers, or sometimes called the cyclist's palsy when you handle the bar of the bike, okay, because of the pressure and your weight probably, then that's how it happens. And then the only way you can see this is by using high resolution ultrasound, 18 to 22 megahertz. And this particular nerve supplies the first dorsal, palmar interossi, adductor pollicis, and deep head of the flexor pollicis brevis. So I did an intervention for this nerve from the pisiform side or from the ulnar side. And it's kind of difficult at first because I have to be careful I don't puncture the ulnar nerve directly. So I tried to separate the fascia. So it's kind of challenging in the beginning because I have to make sure when I infuse the fluid, it doesn't hit the nerve entirely. So I tried to find a way to actually hydrosect, and eventually I was successful enough to separate it from the fascia. And look at the ulnar nerve right here. It is separating from the fascia over here. And then I was successful. I was able to successfully separate this ulnar nerve at the Guyon's canal. So I would like to thank you very much for inviting me again in this forum, and I hope you learned something today. Thank you and